All right. Well, thanks, Chris, for setting up this session. Couple disclaimers, first of all, or at least highlights about what this is about. First thing, this talk is going to be data-free, or at least data light. So for any in the audience, just so you're aware of that. The second is I kind of tried to pattern this talk based on having 1 foot in the clinic and 1 foot in a basic science laboratory, and especially doing discovery-based research. So that's kind of the theme of this discussion of what we need in order to translate or to help make progress in benign prostate research. And I'm going to focus on the prostate, as I often do. So what I want to talk about now is, first of all, is long-term aspirations. That is what, the thing that we want most are new targeted therapies for BPH. I think that is a long-term process. Shorter term goals, which would be precision therapy, and then stemming from that latter discussion, what are the opportunities and challenges in translating these precision type therapies for BPH into the clinic. So let's go first of all to talk about long-term aspirations, which is new targeted therapies for BPH. As you just heard from John Pollock, bulk profiling of BPH, this is from our study, but others have done this, demonstrates that there are things that are dysregulated in BPH, and some of the highest are candidate bioactive ligands. I think as we keep progressing in BPH research or other research related to the prostate, we're going to come up with candidates like these. This is a long slog to figure out how to get these into the clinic. First of all, it's credentialing the pathways. And then second of all, developing ways to inhibit those or potentiate those pathways in a way that's therapeutic. And again, that's, I think, is a very long-term goal. So we've identified these bioactive ligands. Doug Strand has taken it to the next level with single-cell sequencing and actually looks at multiple pathways, and crosstalk has imputed crosstalk in these pathways between cells, such as the you see BMP5 listed there, in crosstalk between these fibroblasts, it was down in the bottom here, fibroblasts and epithelial cells. So again, these pathways are going to, we're going to keep elucidating those pathways. And hopefully from that, we're going to start thinking about ways to deliver therapies. Now, this is long-term. Sometimes just smart science and serendipity can discover other pathways. And you heard from the Wisconsin group, their fascinating work in fibrosis. And this might not end up being such a long-term problem after all. They have some very thoughtful ideas and some pretty provocative preclinical data demonstrating that antifibrotics might be a solution for at least some patients with lower urinary tract symptoms. But I think some of the things we need to progress, and I think probably Will is going to touch on this, is we need better models, especially models, animal models for testing compounds. I think we're going to need maybe some models that we can think about for high throughput screening, which is right now a very fruitful way people are identifying new therapeutic agents. So there's a lot that's got to happen, and we have to figure out how to translate that directly into things like BPH. Those are not easy tasks, and that's why I think this is going to be a long-term goal. So let's switch now to what I think is a shorter-term goal and possibly more achievable, and that is precision therapy. So what is precision therapy? Precision therapy takes what we have. So there are good existing therapies for BPH. They work for some men, but not for others. Right now, there are a few clinical predictors of which one are going to work, aside from doing a rectal exam or getting some imaging and finding prostate size, and know that the big prostates respond best to 5-alpha reductase inhibitors, and small ones don't. So what we need are systems or biomarkers, whatever you will, to better select the appropriate treatment for each patient. And that is not only, the most effective treatment, but also to get rid of futile therapies. Because I have patients that I put on BPH medications for months and months, like 5-alpha reductase inhibitors, and 1 year later, they haven't improved 1 iota. So I'd prefer to go to the therapy that has the higher probability of working first. There's a few necessary things that need to happen in order to do that. First, we need a new way to, if you will, subclass or a new taxonomy for BPH. And I'm going to talk about that very briefly. We need to develop ways to measure these taxonomic types of BPH in the clinic, a practical way of assessing what might be molecularly distinct subtypes of BPH. And then we need to think about exactly what clinical applications we want to target with biomarkers. I've spent much of my career thinking about and designing biomarkers in a variety of contexts, and there's a lot of subtleties to it. So hopefully, this is another thing that we need to think about in terms of translating into the clinic. So first, John just showed you this slide. Using bulk RNA-seq, we identify two subtypes, gene expression subtypes of BPH. Two subtypes was seen in a 2002 publication out of the University of Pittsburgh. A year after we published this, Chris Barbieri's group showed the same thing, and in fact, really replicated our subtypes and used our data set to validate the finding that, there's a stromal type subtype. Perhaps this is the collagen and fibroblast subtype that the University of Wisconsin is very interested in. But at the very least, it looks like you can distinguish a couple subtypes of BPH. Doug Strand has done a lot of work with single cell sequencing. This is a little bit, this is using some of his data, but it also some of our data. So we've touched on this. The North Shore group has done some of this, and Doug has really taken this to a new art. So I think we can also subtype BPH based on the type of cell populations that exist. So it might be another way to parse out BPH into different subtypes that then can be investigated. And what I mean by that is, John showed the slide of, potentially different populations of cells being growing out clonally in BPH and others disappearing. Now that might just be reflected in the bulk RNA-seq data, but it might provide a different way of assaying and classifying BPH. So once you can classify BPH in ways that a clinician can't or a pathologist can't in distinct subtypes, say based on gene expression profiling or cell type profiling, then that sets you up to develop a way of measuring those. And we have to think about how one would like to measure those. I would prefer not doing a biopsy on the patient in order to subtype them, but that is a possibility, and it's been done in some clinical trials. And then basically with having those subtypes, we have at least a toehold for testing whether distinct subtypes respond differently to different therapies. So maybe a fibrotic subtype doesn't respond so well to a 5-alpha reductase inhibitor or to any type of medical therapy. Maybe they need to go right to surgery. So that way we can tailor therapies to keep patients from not having 2 years of misery on medical therapy, and instead just say, look, you're going to go right to an operation where you'll do better. Now, before I move on and talk about the clinical trial design and measuring biomarkers and things like that, I just want to highlight that this discovery work has already been done, but it's really, I think, scratching the surface. I think we have a big problem here with small n. The largest study of BPH transcriptomics at this point is our study at 38 BPH samples. The other two studies had right around 20 samples. We learned from TCGA that there's real benefit to doing 500 samples. And the reason I say that is it helps define less common molecular subtypes, and also the volume of data. Also, it helps you bring out, what is the best signature for defining those subtypes, and what are the pathways active in those subtypes. So I think that one of the things that we could think about as a consortium is how do we put together a large study to do molecular classification of BPH. I want to highlight the problem of spectrum bias. I think spectrum bias happens in a lot of the studies done so far, such as transcriptomics, including our study, including our single cell studies. The problem with spectrum bias is this. You take the biggest prostate you can find in the patient with the highest symptoms, and you compare it to the smallest prostate you can find with a patient with no symptoms. The fact is that probably represents a discrete subtype of BPH. Patients who have terrible, let's say, a large prostate that get an open prostatectomy gives you lovely cells to do your assays. But what it doesn't do is capture the spectrum of the phenotype in patients. So we have to attack that problem of spectrum bias and try and capture the types of BPH and the types of LUTs in patients broadly in order to understand and develop biomarkers that are going to help us triage patients for therapies. We haven't looked at many other technologies that are out there for assessing BPH phenotypes. Barbieri's group showed DNA methylation potentially is different in BPH. There's a bunch of new proteomics, glycoproteomics, metabolomics platforms, and single cell technologies that really have not been deployed in BPH. I think these are all huge opportunities that we should be looking at. I think there's some problems too that we need to understand more deeply on the road to developing ways to phenotype BPH. One is the problem of heterogeneity, and the second is the problem of defining what are going to be useful clinical endpoints that require biomarkers. So I want to just touch on these last two questions in the rest of the talk. So the problem of heterogeneity. We all know BPH is heterogeneous. This is you can see on the left side an MRI. It's all these cystic dilation and all these different shapes within the prostate represent represent the heterogeneity of BPH. You can see it on gross samples. You can see it here in this cross section of one of our BPH samples. You have big cystic dilated glands. You have some that are rich in epithelial proliferation. You have stromal nodules in there. My old mentor, Don Coffey, likened the transition zone to a garbage dump. It really is very heterogeneous. So if we're thinking about developing a biomarker, this is going to be a formidable challenge, potentially, I think. We don't know yet because we don't know what this heterogeneity means in terms of things like potential biomarkers, but we really need to look into and understand in a deep way what this heterogeneity means. Now let's move on now and talk about some thoughts about clinical translation of BPH in molecular and cellular subtypes. So, what do we want to do if we are going to do a taxonomy and think about how to divide up BPH? Well, one thing I see is a classic two-class problem, and I've seen this in several papers, and I've been guilty of it many times also. This happens in the cancer literature. You look for things that distinguish normal from cancer. People have done the same thing, looking at things that distinguish BPH from normal prostate in discovery-based assays. So studies like our transcriptome study, for instance. And you can find differences. You can find a ton of differences. But the fact is, for a diagnostic biomarker for BPH, what's really the need? I'll tell you, a clinician can do pretty well, and a patient can do pretty well together in defining what BPH is in terms of describing what their urinary symptoms are and doing a DRE and showing that there's an enlarged prostate. So that already performs really well in defining the problem. So if you're going to develop diagnostic biomarkers for BPH, you got to add to that somehow or make it better. And that's, that is going to require some thought about how to make it better. And it requires some thought about what is the endpoint that you're really interested in. And we've heard already today from yesterday from a lot of fantastic talks about defining endpoints for BPH and lower urinary tract symptoms. What are these biomarkers going to predict? So let's talk about a couple of the endpoints that we've used in our studies and other people have used. There's a hard endpoint. A hard endpoint is urinary retention. So a patient comes in, they can't urinate because they have a large prostate. Well, how is that as an endpoint? We know from things like MTOPS that happens in about 5% of patients followed over about 5 years. Okay, so that's a pretty rare endpoint. And what that implies is if you're going to collect biosamples like urine or blood samples, you've got to get a lot of patients in your study and bank them in order to see that hard endpoint. So that's not a perfect, but it's, you know, a pretty good endpoint. But it would require a lot of money to do that type of study. And I also would argue that your patients that go into urinary retention, again, might be a spectrum bias problem. It might be a particular set of patients with BPH with more obstructive features as opposed to those with more irritative features, things like frequency, urgency, nocturia. People use surgery, surgical BPH as an endpoint. And that's, again, you know, that's a pretty hard endpoint. If the BPH is bad enough, you get an operation. That's probably a reasonable endpoint. It's not perfect, again, because if you look at some of the studies that have looked at practice patterns of urologists, there are some practices and some individuals that do a ton of TURPs or other types of surgical procedures to unobstruct men with BPH, and some that do very little. Now, is that because they have patients with different risk characteristics? That's possible. It certainly is possible. But it's also possible that the urologist has to make both payments. You know, with that confounder, that is not a perfect endpoint. IPSS, this kind of the standard we've had for many times. I was building a database recently with IPSS to look at our MRI patients. And it's, you know, there's a lot of variation in IPSS. You know, you have patients with an IPSS of 8, which is not very bad. That's just out of the, you know, kind of low to moderate symptoms, but their bothersome index is 6. This is ruining their life. Whereas you have other patients with very high scores, a lot of frequency, urgency, nocturia, et cetera, but they say they're not terribly bothered. I'm glad that the Learn Network is trying to work and they're making real progress in coming up with better ways of measuring this, but it is time for an upgrade on how we quantify this with validated instruments. Prostate volume is another thing I've seen as an endpoint. This is just some data from our MRI patients who get MRI either prior to biopsy or prior to surgery, in which we plot out prostate volume and IPSS score. It's about 800 patients here. And you can see there are some patients that have, you know, not that large a prostate, you know, less than 50 cc's with IPSS scores up above 25, and others that have prostates well over 100 cc's and IPSS scores of 5, right? So, you know, this looks like a shotgun here. This is not a very strong correlation. We've known this for a long time, but it was stunning to see it on our MRI patients. So, you know, again, using prostate volume as an endpoint is going to be kind of a squishy endpoint. So we need to do better than that. So that's, you know, so that's some ideas about, you know, the challenges with measuring what we see in lower urinary tract symptoms in men with BPH. The next thing we have to tackle is what to measure and how to measure it. You know, we can measure things from the blood, like PSA. We can measure prostate cells in the urine, or other urinary type tests and do DNA, RNA analysis, or proteomics, or metabolomics, and things like that. But recognize again that, you know, these biomarkers, it's hard to develop biomarkers like this. They have to have pretty decent performance characteristics in terms of sensitivity and specificity. For instance, the 2-class problem of distinguishing normal from cancer, you'd think that would be trivial given the number of gene expression and protein differences between cancerous and non-cancerous prostate. And, you know, really most of the molecular assays out there don't contribute a lot to clinical practice in prostate cancer. They just aren't used a whole lot. So Matt, I think it's going to be that much harder to come up with biomarkers that distinguish a responder to a non-responder of, let's say, to alpha blocker, but maybe I'm wrong. We just have to do the studies. But, you know, in terms of performance characteristics, that's going to make a big difference. I think MRI has some promise because it can integrate overall that heterogeneity. The only problem with it is it's expensive, but there are things you can do with MRI. You know, MRI, although it is fairly gross, it certainly can distinguish between even histological differences. Remember, at the end of the day, MRI does distinguish between Gleason, low-grade Gleason, it doesn't show up very well, and higher-grade Gleason, which shows up quite well on multiparametric MRI. Also, it's really good at detecting things like stromal epithelial ratios and things like that. So I think MRI has some promise. I think other molecular type imaging that's coming down the pike also could help us. It's just a question of finding the biomarkers to assay in the molecular imaging. Now, the final thing I want to just mention is, so if diagnostic biomarkers, I don't think are the way to go. What are things, if I just sit as a clinician, and I'm sure a good clinician can come up with a lot more questions, what are the things I'd like to have a biomarker for? Well, I'd like to know which guys are going to develop symptomatic BPH as they age, because that tees us up to do a clinical trial, taking men in their 50s and let's say putting them on 5-alpha reductase inhibitors. We know that it, does prevent progression in the MTOPS trial and other trials. Why not take an asymptomatic person with, let's say, genomic risk markers for symptomatic BPH? What patients are at risk for hard endpoints? I mean, patients come in, they have high IPS scores, but they say, hey, I don't want anything done and this doesn't affect my quality of life. Many of them tool along and do fine, but there are some of them that then go into urinary retention and boy, are they unhappy. So I'd like to be able to predict those patients up front who have, obstructive nephropathy, bleeding, recurrent infections, who are at risk for those. Whether or not, I mentioned already, triaging patients for medical therapy so we can pick the right therapy early and spare men from futile therapies. I'd like to know which men who end up going and getting a TURP because they have severe symptoms are not going to have a good outcome from their TURP because they have primary bladder problems. That seems like a very tractable problem. It lends itself to clinical trial design in terms of collecting samples from men who failed TURP versus those who succeed at TURP, preoperatively collecting those samples. I think that's something we could make headway in. Which men are at risk for regrowth or a second procedure? Each one of these suggests a different clinical trial design that I think thoughtful clinicians who do a lot of BPH could help us design well. And these are all things that the taxonomy, the subtypes potentially can help us with. At the end of the day, this is what we want as the happy man. I often joke with medical students that one of the big reasons I went into urology is because there's no man happier who you make pee better. So that is our goal. And I think molecular subtyping and discovery time based assays are going to help us define new therapies, potentially precision therapies. But we have some real challenges in terms of figuring out ways to measure those subtypes and also have to be really thoughtful about our clinical trial design. And on that, I will sign off. Thank you very, very much. And by the way, this has been an outstanding, I congratulate all the speakers. This has really been an outstanding meeting.
So thank you, Jim. That was great. And we're going to hear from Will now. And then after this, we can have some discussion because both of you have talked about the same topic. And then we'll move on to some other areas. Thank you.
Okay, can you hear me?
Yes.
Okay, but you can't see me.
Yes, we can see. Oh, we can't see you.
Okay. Okay, you don't need to see me. Okay. Thank you for the invitation to come speak at Caribou this week. It has been a great meeting thus far, and hopefully continues through the rest of the day. So I too will keep this to more of a conceptual ideas. We won't present any data here. It's more of trying to provide a bigger overview of how translational research is working, particularly coming from the bench side, and some of the tools and some of the biological processes that are important for us to think about. I think after hearing Jim's talk, it'll be obvious that we are looking at things very similarly, but also differently. And I think during the discussion, it'll be great to be able to discuss some of these differences. I think there's just examples where we'll be able to equate how each one is similar and or different. So my name's Will Rickey. I'm the director of the O'Brien Center here at UW-Madison, and I have nothing to disclose. We're charged with, coming up with what does benign urology research need to advance, and I think there's a lot of aspects of this. And for this talk, I want to really focus on three things. One, the understanding of BPH LUTs, and Jim brought up a lot of examples of what we think we know, what we don't know. And I think it's really important that we define what we're saying when we're saying BPH or BPH LUTs. I think we need to be aware, improve awareness to the field. As Jim was mentioning, in the Western world, BPH is not really an issue. We hear plenty of talks over the past couple of days that this is a bothersome disease. But if you look at it worldwide, it's a much different story. As Jim alluded to, if you have BPH untreated, at least in some men, this could lead to acute urinary retention, kidney disease, kidney failure, and ultimately dying a very, very bad death. And so this is something that, again, we don't face in the Western world, but worldwide, this is a much bigger problem. In fact, estimates have come in that BPH through acute urinary retention and kidney failure could cause more deaths than does prostate cancer. So worldwide, this is a major problem that we need to address. The Western world, of course, we need to address for other reasons, but it's all lumped together here. And then the last thing I want to talk about is much like with Jim, is clinical trials and what are the problems and how we can provide a pipeline to better understand how BPH trials how we can help get more clinical trials going. So we've all seen translational research circles like this, where we have the bedside to the bench and the bench to the bedside. And this is going to be kind of the theme that I use throughout the talk. And so, as Jim mentioned, we really do need to look at the clinical side of things. And it's certainly what our center does as a generality, is come up with the clinical problems and then, see how we can address those from the bench. And today we'll be talking about both of these on the clinical side, as well as what we're going to do from a basic science approach. And I think this is important to point out that this is not going to be all inclusive. We have 15 minutes. We'll try to put in the things that make the most sense, and certainly would love to discuss this more with the rest of the group. Ultimately, the basic science hopefully translates back to better patient outcomes, and then this is a perpetual circle that keeps on going till the disease or diseases is cured. So I'll focus our next part of the talk on what is BPH, really defining what BPH is. And this is a recent publication that Matt Grimes, a K-12 scholar here in the Department of Urology, and I wrote up looking at what we describe BPH in the human would look like. So these are urethras. The yellow areas are urethras that, of course, run through the prostate. And in the normal condition, it's very compliant. And when the bladder pushes, the urine can expand the urethra and maximum flow occurs. However, if you look at an obstructed case commonly associated with BPH, you can have BPH nodules that impinge the urethra, making it serving as an obstruction, usually, as Jim was pointing out, dictated by hyperplasia. You can have smooth muscle contractility, that decreasing the urethral lumen and acting as an obstruction. And then, of course, what our center really has focused on is fibrosis. And that is that the fibrosis occurs within the prostate, particularly around or close to the urethra, such that the compliance is rigid and the expansion of that urethra cannot occur as it would back over here in the normal condition. So these are, at least conceptually, what we think of is happening in men with BPH, and there's plenty of association studies that support these. Now, the biggest problem from a basic science approach, of course, is if we want to look at animal modeling, how do we do that? For decades, the mouse and rodents have been considered not a great model to study things like BPH or lower urinary tract dysfunction. mainly because the anatomy is a little bit different. And this is something Chad Vizina discussed a little bit earlier today. And that really, what I have here is the mouse bladder, the lower urinary tract, the urethra, so the urine goes out this way. And here are the prostatic lobes, seminal vesicles. If you look at this in a cartoon from a longitudinal section, you can see here's the bladder, the urine goes out through the urethra and outside the body. And if you take a look at this region here, with as this last slide is showing, this is what the prostatic urethra looks like. So one of the big problems we've had as a field for, again, decades is most basic science researchers will take the dorsolateral prostate or the anterior prostate or the ventral prostate, take a look at those, they just snip them off because they're real easy to take out. They're milligram quantities, so it's something you can actually do work with. But they leave behind all of this tissue here. And the problem, again, is from a translational viewpoint is if prostate enlargement, for argument, calling that BPH, if this VP gets larger, it's going to grow out this way. It's not going to impinge the urethra here. Or if the DLPs get larger, they can grow this way. They're not going to impinge the urethra here. But this tissue here, which is prostatic in nature, as you'll see down here, is commonly overlooked. And so that's where I think we need to look, and we've published on this a number of times. And that's the part from a basic science approach we need to really, I think, get at. So ultimately, when we translate it back to the human, we have to make sure that are things happening in this region or in the prostatic lobes, is this going to be important? Is this what's happening in the human? And so for ease, I'm again heading back to our smooth muscle or hyperplasia or fibrosis or other aspects of BPH that are known to happen within the human. Are those things happening here? And so we can do that. And of course, we need to have the models that appropriately address each one of these concepts or other concepts that link between human and the mouse. And so fortunately, we've developed as a team more than a dozen models over the past 5 to 6 years, including models coming from Chad Vizina's lab, Joe McCoska's lab, Don DeFranco's lab, and many others, as well as mine, where we can start looking and addressing, are these features in human disease also being observed in the mouse? And of course, one way of doing this is looking at the histochemistry through multiplexing. There's a lot of different platforms out there. This is a 7-plex, so 7 different factors are looked at. And this project is being spearheaded by Teresa Liu, a KO1 scholar in our lab. And now you can start identifying the various cell types, the cellular processes, the pathways involved within these various tissues of both human as well as mouse. And this is going to be important in being able to compare between the human and mouse to say, is there something analogous in the human that is occurring in the mouse, and vice versa? And can we utilize that to move forward on other projects? And it's important that we collaborate a lot within our biomedical core, which is headed by Doug Strand at UT Southwestern, a Project 2 leader, as well as Wei Huang, or pathologist here at the University of Wisconsin. And we can see that within particularly Doug's samples, we used to use always TERP samples or prostatectomies, which have their own issues, but Doug has been able to provide samples, clinical data included, that allow us to look both at in situ and vivo aspects of these factors. So we have simple prostatectomies that we can look on hundreds of samples looking for various factors of interest. And I won't belabor this, but obviously this is a very good tool to be able to start translating that into the human side. In addition to immunohistochemistry, Petra Popovic, a KO1 scholar in our lab, is developing multiplexing in situ hybridization. She talked a little bit about this earlier today. And we're also going down that road. But these are very basic science techniques that can apply, I think, to looking at the clinic and problems that we need to address. Okay, so also, as Jim had alluded to, is with regard to heterogeneity, we need to stratify patients when they come into the clinic. And that's a big problem. Currently, and these are generalities, so please take these as generalities only, but a patient may come into the clinic and have so-called BPH LUTs, and what commonly occurs is there'll be an alpha blocker administered. Does that person need the alpha blocker? Maybe, maybe not. If the alpha blocker doesn't work, then the 5-alpha reductase inhibitor could be administered. If that doesn't work, a combination therapy can be utilized. If that doesn't work, then surgery can be used. And again, that's not the only way it happens, but that's certainly a common theme in the urology clinic. So the question is, why are we over-treating patients? If the patients don't need an alpha blocker, why would you give them? If they don't need a 5-ARI, why would you give it? And so I think this is where we need to start saying, okay, is this a problem? I think it is. And can we go back and better understand this in a basic science approach? And so this is where the models can come into play, but also human urine. We've published on a couple aspects of this using either human urine or mouse models urine, normal and disease states, so to speak. And this is a collaboration with Lingjun Li, a world internationally renowned mass spectrometry expert, and Hannah Miles, a graduate student in both of our labs here. Looking at either metabolite fraction or protein fraction. These are things that Jim had brought up earlier, pros and cons to it. Certainly will not dispute that, but the concept is pretty simple. We identify in a disease state versus a non-disease state, either the metabolome or the proteome, excuse me, and then be able to compare back. Ultimately, you can include genomics into this and get a bigger bioinformatics footprint, if you will. And this is with a collaboration with Irene Ong through the University of Wisconsin Carbone Cancer Center, who's really heading up the bioinformatics, bringing these technologies together to come up with potential biomarkers. And this is Han Zhang, a new graduate student in the lab, who's also interested in developing this aspect for benign urology. So certainly I think biomarkers are something that can be utilized. We're going to keep it a little bit more simple in the sense that, are there alpha blockers? Is there a smooth muscle component? Is there a proliferation component? Or is there a fibrosis component? Or potentially, and most likely, interactions between those? Can we identify those in our models, in our patient samples? And that's the low-hanging fruit that we want to take as a first approach to do that. I think that is obvious on how that can help with regard to understanding BPH LUTs a little bit better. We're also looking, as Jim mentioned, in other ways of biomarkers using imaging, MRI, and we heard a little bit about this, and this is a lot of our team looking at this, and we're looking at multiple approaches, but I don't have time to go through that. So lastly, I want to talk about the new therapies that that certainly need to be developed, but there's issues with those. And so for a one drug target, okay, you're probably lucky if there's excitement behind it. Let's say it's an antifibrotic. This is something near and dear to us. Certainly that's something that could be followed up, and we're indeed doing that, in the process of doing that. And I won't talk much about that, but in the last minute or so, what I would like to talk about are the clinical trials themselves, typically needing industry sponsorship. The problem is that there needs to be money. These are industry businesses, and businesses rely, of course, on money. And one of the problems, of course, is there hasn't been many therapeutic advances in the past 20 years. So maybe the antifibrotics or something like that works. I think there's a lot of promise there. But really what I want to focus on here is a new angle to look at. And that is taking drugs that already exist that companies might not be interested in promoting because they're either on patent or we're off patent, and they're not going to be able to make money. And I was talking, very fortunately, talking to an old friend and colleague from the days of the University of Missouri that we both spent some time at, Dr. Len McGilvery, who's now the chair of the Department of Chemistry at the University of Iowa. And he was telling me about a drug called Entresto and how co-crystals can occur. Co-crystallization is, and I'm going to butcher this, Len, but I'm not a chemist, but if you take two compounds and they're able to co-crystallize, and in my world, you just mix the two together, they're going to co-crystallize and away you go. clearly it's much more difficult than that. And that's why experts like Len are involved in these processes. But what's interesting about this is that the FDA has put out that if you have a co-crystal, even if they're patented or off patent molecules, if they do co-crystallize together, they are now patentable as a new project or as a new compound. So Len was telling me about Entresto, and they did exactly that. This made millions of dollars, and it's really the poster child for new drugs in the future. So being able to develop drugs that are already present, perhaps package them in a new way for co-crystallization. If they work well, obviously clinical trials may be able to continue on with drugs that are already in the field and already well known. And hopefully next year, Len will be able to talk as he has a pilot project looking at co-crystals and benign urologic research, taking for example, compound 1 and 2, put your favorite one of interest in there, coming up with a new drug, and then therefore being able to test it. And both Adrian and Alexis, Adrian, excuse me, and Maggie Stangus, 2 students in the lab, will be taking this type of technology, moving it forward in the near future. So I think I've given you, I hope I've given you a good pipeline for how we can utilize basic science and improving our translational science, ultimately hoping to assist in the clinical outputs for better treatment for our patients. I'd like to thank my lab, of course, all the center collaborators that have contributed to this a large amount of work, and especially the NIH funding that supported all this work. So thank you.
Excellent. I put in the chat a suggestion for how I think we should structure this. Does that look good to everybody? Okay, so let's have some discussion, and the hope really is that because we're recording this, and we really are going to use these talks for future discussions among trainees, among all of us, really, as we develop frameworks for each of these areas that we study, so that we can sort of at least have a big picture sort of view of what it is that we need to do as a community of researchers, and then we can identify who's filling in, who's doing what. And that's just one idea for a deliverable or an outcome of this. But let's just open it up and hear what people think about these 2 perspectives on benign prostate.
Hi, can I ask something? Yeah, hi. This is for both Jim as well as Ricky. Great talks. I mean, yes, you actually highlighted all the areas where kind of the need is there for the BPH to progress. My question to you both is, what do you envision as some of the, kind of resources that you would like to see that are missing, especially in the light of, all the talks that I have actually heard? I saw very little emphasis on the in vitro models. And when you talk about, identifying new therapeutic targets or even testing or high throughput screening, some of these models, might be needed, especially, there was some discussion about the organoids. So what is your take on actually having these kind of models that would actually aid in the further progression of finding new, therapeutic targets or biomarkers for BPH?
Yeah, so Jim, I'll take a first crack at this if you don't mind.
Yeah, I'd appreciate it if you would.
So Deepak, I think this is a great question, and it's a very problematic one. And the reason being is, I think most of us, again, we think we know what BPH is, and you're going to put it, if you look at the textbooks, it's going to be nodular growth. But even within nodular growth, there's glandular growth, there's stromal growth, there's different versions of each of those. Jim was talking about the heterogeneity within any given sample of that. And so if we think of it as just one type of disease, we're never going to solve the problem. Now, let's just be extreme or dramatic about this and say, actually, there's 100 different things in there. And BPH is really 100 different diseases that culminate into one of urinary symptom. Well, of course, you're going to have a model for each one of those because it's very unlikely that the same molecular target is going to be involved in all. Now, that's what we want. That's what the drug companies want. But if we have that type of approach, it's just never going to work to have one size fits all. You have to be able to model each aspect of the disease that we see in the human. The problem is we don't know what all those so-called types or subtypes, as Jim was putting it, that are out there, but we got to start somewhere. And so from our perspective, you know, we look at hyperplasia, that's a big ball of wax there. Multiple types of BPH are going to be involved there. Smooth muscle contractility, the same thing. Fibrosis, the same thing, let alone if there's interactions amongst those. But I think we have to start somewhere, and we have to see what models we do have available. 10 years ago, we don't have the models that we have today. So I really expect that with the models that we have, and they're pretty straightforward models, these are not very elaborate models, although there are those as well. But now many more researchers can get involved. And this is certainly something NIDDK has wanted for a long time, is we need more investigators. I could not agree with you more. But if they're going to study cell culture and say how that relates to urination, that's where we've been for 50 years. That's not going to be helpful. It's going to be helpful for a molecular mechanism at this stage in time, but we need to have some models that actually have a physiological consequence to them and actually can be related to the human. If they're not related to the human, again, it becomes a little bit problematic. So I think there's more models out there to be made. The models that we do have need to be further characterized. But then getting back to your the other tools like RNA-seq and those type of results, again, 10 years ago when we first started looking at this, there wasn't much sharing. There wasn't much RNA-seq or microarray analysis. Now there is. Doug's got some, Barbari's got some, Jim has some. There's more and more of that data starting to come in that we can start putting into the big banks and applying it to the human condition, to the mouse condition, modeling condition that is, and proteomics, metabolomics, all those things are going to start building. And I think really it's ripe for the picking moving forward to being able to define some of this and really start making headway towards getting this stuff into the clinic. So I know that was a little bit longer than probably what you were thinking, Deepak, but that was my 2 cents.
Yeah, I'll just add a couple. I'll add a couple comments. In my view, I am quite worried about model systems. I think in BPH, BPH is a kind of, best as I can tell, it's a human disease. Now, mind you, dogs get big prostates, things like that, but this enlargement with LUTs related to obstruction from the prostate, I think it might be uniquely a human phenomenon. Hopefully I'm wrong about that. And that kind of hamstrings us a little bit. I do think that there's a lot you can learn from animal models, but for modeling, for preclinical development, we have to be really thoughtful. In terms of this is our bias, and I'll tell you frankly, this is a bias. So that's why our group is very focused on human disease. For the human disease, I mentioned this in passing, and I want to circle back to it. And Kathy Mendelson messaged me about this. There's really room for a TCGA for BPH. If you look at what's happened since TCGA, I was in the TCGA pilot study many years ago. Those data sets get used to death. They really get used over and over and over again. And I think that is a valuable resource that could be contributed. And I agree with Will, there's now technologies that would allow us to do a really good job of doing a taxonomy. But the other thing we've learned from cancer anyway is that, cancer is easy in a way. You have a mutation that, screws up a pathway and you target that pathway. We don't have driver mutations. That being said, there is evidence that perturbations of pathways that are not due to mutations in cancer can still respond to targeted therapy. So that to me gives me hope that if we identify the pathways, and particularly pathways, there might be pathways in different subtypes as Will alludes to, and God help me, I hope there's not 100 of them, but I I do hope that there's discrete subtypes. We've seen it over and over and over again in other diseases. And if we actually can define those pathways, then we're on the road to developing a therapy. High throughput screens you mentioned, that one I have not given a lot of thought to, and I think that is a great thing for the consortium to think about. What would be the readout in an in vitro study that one needs to have? And again, that probably means identifying a pathway in order to do a high throughput
No, you don't have
screen.
to do that. You could take tissue from human samples and do organoids.
You can do
That's
organoids. We've been doing
That's what
tissue-
Michael Shen does with the
Yeah, we've
bladder.
been doing tissue slice cultures. We're working on other technologies right now.
But I
to
meant,
do.
you know, I just
Yeah.
want to say that, but I also wanted to say that I wanted to ask you. So I've been trying to think, I love this experiment. I actually said it to one of the program directors about 4 years ago, and she told me she wasn't interested. But anyway, I won't mention any names. How do you imagine? So I love the TCGA. How do you, and one point, bladder cancer is from smoking. Smoking causes the mutations. So there's also other ways of acquiring mutations besides, you know what I mean?
Sure.
But how do you handle 100 samples? They're old people, right? Just like cancer. And how do you get the data? So how would you get the immune data and the cellular data? Is the idea to do single cell? Will you get enough in the tissue samples to do single cell? You know, I'm just trying to think it out in my head how you would do this, because you want all the cells, not just the epithelia, right?
Yeah. It's the old problem of trying to design a perfect experiment. I don't know that I ever have in my whole career, right?
No, none of us have.
Yeah. So yes, there's a lot to learn from single cell. There's a lot of things that are really, really hard about single cell. In terms of getting adequate cell population representation and things like that we've run into anyway. Maybe we're not good at it.
No, everybody.
But there are ways, again, if you look at bulk transcript data, people have invented, CyberSort 2 now that allows you to impute from expression data the different immune cell types. And then you go on and you validate that, right? And you can validate that by, using your IHC, immunofluorescence techniques, or multiplex it the way we talk about. So I think I think this could be multi-layered, but just having that one database, the TCGA type database, would help a lot of researchers. I think it would. It depends on how one would structure. I mean, this could be something we talk about as a community about how to do this, and see if we can persuade people that that's a good idea. I mean, do you do it like TCGA, where each site had their own specific thing they did? One site did methylation, one did copy number, one did transcript, or how do you want to do it?
Their samples also were very particular,
Yep.
right? They were primary tumors.
Yeah,
And
and
there's all
some,
kinds of other things to
well,
deal
they
with,
had some, they had their own problems with spectrum bias there. So, for instance, the glioblastoma samples that they looked at, I was involved in that. They had to be highly cellular. Well, that's a pretty necrotic tumor many times. So all the necrotic tumors were kicked out. So, the same is true in a variety of other cancer types. So anyway, that's neither here nor there. But I think, maybe you have a site that does tissue acquisition and processing. I certainly heard from North Shore and Texas Southwestern. They've got a lot of samples. We have a lot of FFPE samples here. So I think there's ways to do that, but it has to be done really thoughtfully.
I'm going to jump in.
I think there's more opportunities now too with FFPE tissues. TCGA originally was dependent on fresh tissues, but FFPE works at this point.
I'm just going to jump in and just say this is obviously, not a complete conversation, and it's just the beginning of one, but it's kind of a good segue to the next talk. So I'd like to introduce Kathy. And after Kathy, there are two more people named Catherine who will also be talking, which I think is pretty cool. So go ahead, Kathy Mendelson.
It's actually Greg who's talking.
Okay.
Greg Whittemore, sorry, who's a fourth year medical student taking a little hiatus. He's working with Simone Sanakerke and with me. I'm sorry.
It's okay. He can be an honorary Catherine for the day.
Okay.
Excellent. Sounds good to me. Hold on, let me just see if I can get my slides to share a little better. I'm trying to get the presenter mode thing here to work a little bit better than this.
We love to hear from young people anyway.
Sounds good to me. All right, I think I will just go with this. So as Kathy mentioned, I'm Greg Whittemore. I'm a fourth-year medical student at Columbia and Kathy's lab, as well as Simone Santakirky's lab. So I'm interested in applying into urology next fall. And I just wanted to take a quick second and just thank the NIDDK, Caribou, and Chris and all of the organizers for putting this meeting together. This is my second year going to this, and it's such an awesome meeting. I really learned so much from all of you. So there's two main things I really wanted to talk about. The first one, as Chris kind of alluded to, is why the field of benign bladder research could also use a genomic atlas similar to TCGA. But the first thing I actually really want to start with here is to briefly just discuss some hallmarks of urothelial damage and discuss why we could possibly make some kind of urine test to use some of the markers of that to maybe stratify patients based on urothelial damage from the urine. So just a quick whirlwind tour of the urothelium, given that Kathy already talked a lot about it this morning. So the urothelium is the epithelia that lines the bladder. It's a watertight and soluble barrier and also prevents bacterial adherence. It also has some sensory roles and signal transduction roles modulating the muscle function. So there's four main cell types in the adult bladder. That's the superficial luminal S cells here that stain for uroplakins. That's what gives them their main functional character. They also have a number of tight junctions. There's the intermediate cells or I cells. These are the progenitors for the S cells at homeostasis. And then the two basal populations. The main one is the K5 basal cells, which make up about 90% of the basal layer, and then the K14 positive cells. So those are only about 10% of the basal urothelium, and they can function as progenitors, but at homeostasis, they really don't. So then also, I just wanted to briefly discuss a couple differences between the mouse urothelium and the human urothelium. So the main differences we really see is that there's more cell layers in the human urothelium. So they don't just have one layer of I cells, they actually have two. So one of those is anchored to the basement membrane by the cytoplasmic tail. The other difference being that rather than a K14 basal population, they have two separate K5 populations, and they're distinguished from each other by their expression of PPAR gamma and FABP4. So there's two different classes of urothelial progenitors, as I briefly mentioned. So homeostasis, the main ones are the I cells. Those differentiate into the S cells to repair the urothelium after acute or minor injury. And then also at homeostasis, if the S cells just die off, they're the ones that are really doing the heavy lifting there. So you have the I cells that self-renew and can form S cells. And then in homeostasis, the K14 basal cells, which can be progenitors, mostly just self-renew, they don't really differentiate. But after chronic or serious injuries, these I cells are either depleted or lose their regenerative potential, in which case the K14 cells are the ones really taking over. So those can actually regenerate an entire urothelium de novo. It's worth noting, though, that this is a very rare event. And so in this case, you have the K14 cells giving rise to the K5 basal cells and the I cells, which then mature into superficial cells. So worth noting here, at homeostasis, the urothelium is one of the most quiescent epithelia in the body. So it really turns over very, very slowly. It has a half-life of 40 weeks. So these cells divide very slowly. So that being said, though, it can rapidly regenerate after injury. So looking at a UTI model of injury, you see at 2 hours that you have inflammation that is up based on the overexpression of NF-kappa B. And then you can actually see the infection of the superficial cells, as you can see with these GFP labeled E. coli. Then by 12 to 18 hours, you have a rapid exfoliation. You can actually see some denuded submucosa here. You can actually see, again, an infected superficial cell. By 24 hours, you're starting to see proliferation of the basal populations and progenitor populations. By 48 hours, you start to see more mature cell types, and this whole process wraps up by about 72 hours. So focusing though on this 24-hour time period, there's two things that are kind of interesting. First of all, you see an increased expression from the RNA-seq of a 24-hour post-UTI sample of keratin 14. So you are potentially seeing some proliferation of these keratin 14 cells. But then additionally, you see expression of keratin 6A. So this is a marker of activation of those keratin 14 basal cells that's not expressed at homeostasis in the urothelium at all. And as I mentioned earlier, in the human, you don't really see any keratin 14 positive cells at homeostasis, but it is worth noting that you do get keratin 14 expression with like very severe damage, or in the case of urothelial carcinomas. So we know the urothelium in humans is capable of expressing keratin 14. So just to highlight this a little more here, this is a mouse that hasn't been injured in any way. You can see here that a very small subset of the basal cells are expressing keratin 14. You don't have any keratin 6. There's not really any inflammation to be seen based on the lack of CD45 positive cells. But in two different models of a more severe or chronic injury using either BBN, so this is an irritant that you can find in tobacco smoke, which also is capable of causing cancer with more prolonged exposure. But when you give it for 1 month, it just causes massive inflammation and injury. Or otherwise giving cyclophosphamide, which is a chemotherapeutic agent used in a number of cancers, as well as in several autoimmune conditions, including nephrotic syndrome. You can also induce injury to the urothelium that way. So when you give 1 dose of cyclophosphamide, it looks more like a UTI situation where you shed your urothelial cells and they're replaced by 72 hours. But when you give 5 doses of it, it looks more like a chronic effect like BBN. So here you can see in the middle panels here, this is 5 doses of cyclophosphamide. And then in the bottom, you can see 1 month of BBN exposure, giving BBN in the water to the mice. So you see a massive expansion of this keratin 14 population. And also those cells are co-expressing keratin 6A, this marker of basal cell activation that you don't see at homeostasis. And just to further illustrate the injury here and the inflammation, you can see you have massive edema in the bladders on the H&E stain for both the cyclophosphamide model and BBN model as compared to the non-injured model. And then additionally, you see infiltration of CD45 positive immune cells. So when you do this kind of injury model, you end up seeing a depletion of the normal luminal markers, including keratin 20, keratin 18, PPAR gamma, GATA3. And instead, you see an expansion of these activated urothelial cells that express keratin 14. And then they also express these other keratins, which are sometimes referred to as defensins, like keratin 6A, keratin 16, that you don't see in a healthy urothelium. So these being markers of injury and activation of this cell population. So activated basal cells form in response to injury, and they prime the urothelium for tumor formation. So it's a stereotyped injury response that occurs not just in the urothelium, but also other epithelial barriers as well, where you have these keratin 14 positive basal cells expanding and expressing these defensin keratins. So this happens in the skin, it happens in the airway as a means of protection, basically to plug a hole when you're causing damage to that epithelial barrier. So you have a K14 basal cell, you have some kind of insult to it that activates to express keratin 16, keratin 6A, and then either it recovers. And that's often what happens when you have a more acute injury, and that's more of like a transient response. But if you have a sustained response of this in the context of a more severe injury or also a chronic injury, you end up possibly even getting a squamous differentiation, given that keratin 6A and keratin 16 are markers of squamous cells, and then that can progress to cancer. So basically my question here is, can we use what we know about keratin 6A and keratin 14 as basically hallmarks of urothelial damage as a means of kind of taking the temperature of the bladder, basically serving as a red flag for injury to help number one, just understand pathophysiology of some of these diseases and have a non-invasive way of assessing this other than just going straight to cystoscopy. And then can we basically just use keratin 6A, keratin 14 in particular as biomarkers in the urine. So what a test like this might look like, as well as where this might help. So again, might be a red flag for urothelial injury. Also, it might help aid in diagnosis, management, and prognostication for a number of the benign bladder diseases. This is definitely an incomplete list here, but just the main ones jumping out being LUT-D, LUTS, UTI, any variety of iatrogenic or idiopathic urothelial damage, including things like mesh erosions, also chemotherapeutic agents, might be less useful in the context of things like interstitial cystitis, given that the way the urothelium responds in those contexts doesn't seem to be exactly the same as what we saw with the UTI model or those chemical injury models that I just showed you. Lastly, it could kind of help triage patients for imaging and cystoscopy, perhaps. So in busier practices that don't have as many providers, it might be a way to help decide who needs to get an MRI sooner, as well as who needs to get a cystoscopy sooner. So then just a couple ideas I had of what this might look like. You might be able to do an ELISA to actually just test for the proteins in the urine. Alternatively, you could couple cytology with immunofluorescence and just look for keratin 14, keratin 6A positive cells. Or alternatively, given that you also see increases in the mRNA in these injury contexts, you might be able to just do an RT-PCR. So now for the next portion of my talk, I wanted to focus more on creating something more like a TCGA, as you guys were just previously talking about with the prostate, for benign bladder diseases, and just see what that might look like and see if people think that this might be something that's useful. So it's the Cancer Genome Atlas, which was, I believe, started in 2006 and wrapped up in 2018, was very, very successful. And there's a number of things that it really helped do that might help out in the benign bladder field. So number one, it might help us dissect the molecularly distinct subtypes of disease. So a lot of these conditions are really defined based on clinical symptoms at the moment, and the pathophysiology is not very well understood. So it's quite possible that a number of these things are really a bunch of heterogeneous diseases with different etiologies that all just get lumped into one bigger category. So this would kind of help us dissect that out if we did sequencing and unsupervised clustering like they did with TCGA. Also, just to better characterize molecular pathophysiology. And then we could also discover biomarkers for diagnosis, prognostics, and treatment monitoring. And then, as you guys were mentioning, we could also identify pathways that are important in these different disease subtypes to prioritize interventions with either agents that are currently available or guide novel drug discovery. We might be able to even use some of this data to identify genetic risk factors. As Dr. Garavi was mentioning in his talk yesterday, the genetics of the adult benign bladder diseases and lower urinary tract in general are pretty underexplored at the moment. So there's a lot of opportunity for that. So this might be one way to really help start exploring some of that. And then lastly, it might allow us to develop preventative treatments for patients at risk for any of these diseases. So where would we start for this? A good first place would probably be a single cell atlas of healthy adult bladder. And given what we heard from Doug Strand yesterday, he's actually collecting bladders from healthy adults, both male and female, from their organ donor network down in Texas. And in collaboration with Kathy, the two of them have started to put together an atlas of single cell data for both healthy human bladder as well as healthy mouse data. So this is just some unpublished data that both Doug and Kathy have given me permission to show here. So then, given that we have control tissue, what's the next step? Well, we need to acquire diseased bladder tissue. And the question here is really, how do you go about doing that? So we can do postmortem bladder recovery like we've done for the healthy bladders, but there are some pitfalls here. Number one, the lack of adequate clinical data and being restricted to only doing like retrospective analysis of the clinical data. So you really don't know any of the symptoms of these patients. You can really only just make molecular correlations. Another alternative would be to do bladder biopsies. So when you're doing cystoscopies on patients for rule out bladder cancer or any number of other indications, perhaps getting a piece of tissue like some kind of core biopsy, which I know that there's been some studies that have looked at the utility of that in the cancer realm, but it's something that's not really in common practice in cystoscopies otherwise. So the limitations of that obviously being that you have less tissue to look at, you might miss any relevant anatomical or functional structures given that you're only getting a couple small cores of tissue. But that being said, it is an adequate amount of tissue to do sequencing. And then you can also get a lot of omics data off of that small little bit of tissue when you're leveraging the technologies like spatial transcriptomics, like Doug was talking about yesterday. So here's just a cystoscope. Here's basically a punch biopsy setup that they did for this bladder cancer study. And this is just showing how that's implemented. We could also use biobanks like Doug's biobank that he has using formalin fixed paraffin embedded tissue, as well as any other biobanks that happen to have bladder samples. But again, it really comes down to, do we have enough clinical annotation to understand, like for instance, like we saw with the prostate, do we know what their IPSS score was? So, because that would be very useful in working up patients with LUTs and understanding what basically molecular subtypes of disease present with what symptoms and being able to kind of do those correlations. Lastly, we could get blood samples from these patients and do something like a genome-wide association study like Dr. Garavi does, or also now that we could leverage the EHR a little bit better, we could also do a phenome-wide association study and basically flip the design around and say, given the phenotypes, what markers are associating as opposed to what markers associate with what phenotypes, if I'm understanding that correctly. So then we have the tissue. What do we do with it? So again, like they did with TCGA, you can do a whole number of sequencing technologies like RNA-seq. You can look at copy number variants, whole genome sequencing. You can sequence the epigenome with things like ATAC-seq or use any other number of epigenome sequencing methods like Fairy-seq, DNA-seq, and then run the unsupervised clustering. So this is the most recent paper from the muscle invasive bladder cancer field, where they managed to find the molecular signatures from this unsupervised clustering and identify multiple different subtypes of muscle invasive bladder cancer. And then lastly, when you have smaller pieces of tissue, whether that be from biobanks or from biopsies, assuming that we got that kind of protocol rolling out, then you can do things like spatial transcriptomics, which are very useful because you get a lot of omics data off of one slide of tissue that's well preserved. And also it has the advantage of giving you the spatial context as well as the molecular differences of the different cell types between health and disease. Here are just two examples. This is an example actually from a pamphlet from Illumina. This is a sample of human kidney from diabetic nephropathy, where you can actually see here's a healthy glomerulus right next to two abnormal glomeruli. And then here's an example from prostate cancer. So if we can leverage a similar sort of set of approaches in benign bladder disease, I think that would be very useful in helping us to kind of dissect out different molecular subtypes and molecular pathophysiology of a number of these conditions and help us find better ways to treat this.
I'm just going to jump. Oh, you're at your end. That's good. Okay.
That's my end. Yep. So I just wanted to take a quick second and just acknowledge everyone who helped make all of this research I showed possible, as well as for helping me along my early path here in research. So everyone from the Mendelsohn lab, everyone from the Santa Kirky lab, both my mentors, Kathy and Simone, Doug Strand for the data he let us show here, all the funding sources that helped make this possible for me at Columbia, the Columbia U54 Center, and then lastly, and most importantly, NIH, NIDDK, and Caribou for all of their funding support that helps all of our projects at Columbia keep running. Thanks, everybody.
That was a very nice talk. In the interest of time, and because it actually kind of is an interesting segue, I'd like to move on so we don't give short shrift to the two remaining speakers, to Catherine Brownstein, who, Greg just talked about, a genomics sort of atlas, and I think what Catherine's going to do is give us some perspectives on how we should be doing that carefully and with purpose, and a lot more than that. So go ahead, Catherine.
Thanks so much. So now for something completely different, well, not very completely different, but somewhat different. I'm speaking today on the need for diversity in urology genetics research, and I'm going to give some examples, state the problems, give possible solutions, and hopefully leave you with a sense of urgency and a call to action. So before I begin, I have to give a brief overview of the genetic diagnostics and discovery process, probably not necessary for this crowd, but since it's being recorded, who knows. First, once you identify a family with a rare or undiagnosed disease, you consent and enroll them to your study. You eliminate known causes and genes. For example, you do single gene sequencing. And if that fails, you reflex to next-gen sequencing, a lot of times exome, microarray, or any other tool you have in your arsenal, long-range sequencing, epigenetics, transcriptome. And then you generate a list of candidate genes using the available bioinformatics tools and inheritance patterns, or again, whatever else you have at your disposal, and come up with a short list of variants. Then you confirm that the variant is not a normal rare variant in the healthy controls. More on this, much more on this later. And you find additional patients and ideally do functional testing to prove biologic effect. So I just grabbed, to illustrate this process, I just grabbed from my cohort a patient with a urogenital disorder that was unsolved. This patient is Caucasian in background, and I went through this process. I loaded it into a browser that I really enjoy and find easy to use called Codified Genomics. I put in the keyword urogenital and ordered by allele frequency in database populations. You can see it's a relatively short list. Again, this is an undiagnosed patient, so we probably would have reflexed to genome if this was, or I think this is actually genome, so we would have reflexed to long range or some other type of study to try and figure out what's going on. But there are two candidate genes that are not seen in any database and warrant further investigation, look at zygosity and whether or not they could be possibly diagnostic. So then I went back to the database and I grabbed the first non-white patient that I could find that also had a urogenital disorder. I did the same thing. It was loaded into Codified. I ordered it by frequency, or used the keyword urogenital and ordered the frequency by frequency. You can see that in contrast to the 6 variants total that came up, 33 came up, and 8 or so had not been seen in any database. Now, I just grabbed these patients right away. So perhaps I just got unlucky. And again, this is, you see much more in variation in the non-Caucasian patient. This is actually a patient from South Africa in a small ethnicity, rare ethnicity. So I went back to the database, grabbed a Caucasian patient with a kidney malformation. This is a Caucasian patient, ran it through the protocol, ordered it by frequency, and you have around 1,071 variants that are genes that are associated with kidney disorders. Again, we expected a huge number here because kidneys are associated with a lot of disorders, and expression comes up here too if it's the top expression or top 3. And you have around 500 variants that have not been seen in any database, gene variants. Repeat it again, grab the first non-Caucasian patient I could find. This here is a Southeast Asian patient with a kidney malformation, did the same thing. Instead of 1,100 rare variants, we have 3,400 rare variants that come up associated with rare variants in genes associated with kidney disorders, and around 700 that have not been seen in any database. So what do you do when you have how do you interpret 700 variants? Like, how do you interpret candidates when there are so many candidates when you're going through the gene discovery process? So for example, with this last patient, there is a CHD7 variant that's not seen in any database. It's extremely conserved when you look at different species. And when you use ACMG criteria, screening criteria, which is a uniform set of criteria used to score variants, it says that it's a variant of unknown significance leaning pathogenic. But here you can't really use ACMG screening criteria because it takes allele frequency into account. And because this is a Southeast Asian patient, we don't know if this variant is a complete novel variant, or if it's kind of common in a Southeast Asian population that we just haven't screened very much of. And again, now when you look at the protein prediction programs, which I'm sure someone's going to say, oh, just look at the protein prediction, it comes out as benign. So, but then you're not supposed to totally rely on these protein prediction programs. Sometimes they're not actually that good. And you don't want to eliminate something. Like, we've all come across variants that, like, perhaps aren't the most predicted to be the most damaging, but can have a milder phenotype, especially something like with Charge syndrome, which CHD7 is associated with, where you can have a lot of variation in the phenotype. So how do you interpret this when there's hundreds just like it? In addition, you have standardized tools like polygenic risk scores that aren't working as well in non-white patients because they were designed using white patients or Caucasian patients. So this example, this is not in your urology research. My background is a lot in schizophrenia, and the polygenic risk scores for schizophrenia work quite well, some of them in Caucasian populations, but do not reflect true disease risk in non-white populations. And you have to state that very cleanly and plainly, and is the reason why PRS replicability needs to be improved before PRS can be used in the clinic for a lot of these types of scores. So in case you spaced out or it was too long, didn't pay attention, the takeaway for this far is that analysis, discovery, and diagnosis for non-Caucasian patients is a lot of times difficult because we don't know if something is disease causing or just rare, and are we creating tools that are completely equitable, that they work in all people equally, and if not, how do we fix this? So given this situation, I tried to break it down into different sub-problems and talk about possible solutions. So one thing is the lagging diversity within the scientific community. If you have people from all over the world, they're going to be enthusiastic, take what they've learned, and really establish it wherever they may go. So having initiatives to foster the careers of researchers from all over the world in diverse backgrounds is amazing. In urology, we can encourage international trainees and collaborations and create infrastructure to allow for queries. So I did my PhD, actually, that's where I met Dr. Garavi. And I learned in the Lifton lab, we heard probably 10 languages each day. And if I need to figure out if something from the Middle East is a rare variant or a common variant in certain populations, I have people I can email and ask them to query their databases right away. But I'm extremely lucky. Those databases don't exist, aren't readily available for a lot of people. So tools like Matchmaker Exchange are wonderful in that you can deposit in a variant and gene with the phenotype associated and see if that actually is a reasonable candidate, and if anyone else around the world has considered it to be a candidate too. But that helps if you're on the right path, but it doesn't really assist if you're completely barking up the wrong tree and you're not going to get a hit. And it's really just because we haven't, the databases and the infrastructure that we have at our disposal so far is not quite good enough. So the problem here is that we don't have a diverse foundation for what we're doing a lot of this genetic work on, and everything is built on the same foundation. So we have a preference of researchers to analyze data from well-characterized, well-powered, publicly available cohorts with known ancestry, but a lot of these are primarily European ancestry. So Nomad is the biggest gold standard database that we have right now. I just picked a random variant. And yes, they break it down by African and African American, but when you look at the total allele numbers, it's less than 10% of the database. And also Africa is huge. So by saying just African American, we don't actually know the distribution and the comprehensiveness of the surveying. So the solution here is to just keep on sequencing, keep depositing, keep figuring out how to get increased numbers and make them publicly available. And then to incentivize research. And maybe even penalize lack of diversity at the stage of funding and publication, and also to really promote and use the more diverse databases that we have available to us, such as All of Us, H3 Africa, TopMed, and PAGE. So, so here's an example of how growing cohorts really works. Again, I'm sorry, I'm going back to a non-urology example, but one that I know is quite striking in SCN1A. When it was linked to Dravet syndrome and epilepsy syndromes, there was a tendency to think all rare variation with an epileptic patient was pathogenic. And as a result, a lot of things were classified as pathogenic when more and more people started getting sequenced. You were finding in the general non-epileptic population. So this paper in 2016 went back and looked at allele frequencies and potential pathogenicity of a lot of these variants and went back and reclassified them, many of which are no longer considered pathogenic. And a quick view through ClinVar shows exactly that, where in 2014, a variant was considered uncertain significance, and in 2018 is now, or 2019 went from likely benign to now considered to be benign, a benign variant. The other problem is that funding is tough as it is. Like when you're trying to come up with a project and you want it to be funded and as scientifically sound as possible, it's really hard to go for the smaller sample size, even if it's more diverse, or to emphasize, use limited funding on making their sample size more diverse. So really, we have to emphasize the need for reviewers to value diversity and understand the complexities and challenges of having a diverse sample. And then also to work with already available resources. So a lot of campuses already have a diversity and inclusion office. They're a lot of times willing to help to review grants, to provide guidelines for reviewing grants, and getting their input on making sure that you are selecting the next generation of researchers that value diversity is paramount. Then finally, technology limitations are an issue. And here is something as simple as interpretive software, where you know that it was trained on Caucasian patients, or to know that array or something was not developed with diversity in mind. And a baby step towards doing this is to just note where it's not totally representative, whether it's an abstract, or to understand that, okay, in the conclusions that what you've worked on actually perhaps is not completely generalizable. This is again, or make an effort to understand that training something on non-white populations may take a little more work. Here is a polygenic risk score for Asian populations on prostate cancer that was developed to tailored to Asian males. And then lastly is to do the work yourself. And here is my project on interstitial cystitis that I've worked on thanks to the Caribou program in Colombia. And I inherited this cohort that was over 15 to 20 years old, and it's 95% Caucasian. So it's very easy for me to kind of shrug my shoulders and keep working because I only have a limited amount of funding to do this, but I understand that really anything that I find is not going to be completely generalizable, and that I need to form collaborations and get diversify the cohorts somehow and in some way. So the way I'm doing it right now is working with Inspire.com and the Morehouse School of Medicine to diversify my cohort, to recruit non-white patients, and basically backfill to create as robust data as I have for the Caucasian patients that have been collected for over 15 years. And it's going to be challenging. I know that I'm going to have to write supplements in order to be able to hit the target numbers that I want, but I know that this is very important work and has to be done. So in conclusion, diversity in faculty and in patients will improve diagnostics and discovery in urology and in all research. And the road to getting there requires collaborations, infrastructure, the use and development of diverse reference databases, which goes back to item number 1. We need to stop just shrugging our shoulders and accepting it when diversity hasn't been taken into account, even when that work is hard. Especially when the only well-characterized and sizable cohorts are a majority Caucasian. Finally, we have to internalize individual responsibility to improve the situations here. So in conclusion, thank you so much to the Columbia O'Brien Urology Center, Inspire, who is helping me diversify my own cohort, and the Interstitial Cystitis Association, Boston Children's Hospital, and then the HMS Diversity and Conclusion Community Partnership Department at Harvard Medical School, and Armosha Hill, who actually proofed this deck for me to make sure that I didn't miss anything major, and then the Morehouse School of Medicine. Thanks.
Hello. Did you want to discuss this for a couple of minutes, or should we go right into our last speaker?
Okay, I'll send the slides.
Thanks so much.
Any thoughts?
What, did I miss something? No.
Let's just move on to Catherine Putanti then. Kathy, I didn't hear you if you were saying something.
Did I miss something?
No, we're going to go on.
Just took a break.
Okay. We're going to go on. So thank you. And I'd like to now introduce Catherine Putanti, who is also an Opportunity Pool awardee from the Columbia University O'Brien Center. This is, well, anyway, so go ahead, Catherine. She's sharing her screen. Great.
Okay, great. Yeah. All right. So thank you very much for the opportunity to speak. When asked to speak today, I was given this title, and I thought this was great because it really comes on the heels of a recent paper that I was privileged to be a member of. And so if you haven't checked this out, last year in M Systems, we put together a consensus paper on urobiome research. And this actually came out of discussions from our annual urobiome conference that we have, in which microbiologists, bioinformaticians, genomicists, as well as clinicians were talking about the methods that they were using in their own urobiome studies. And we recognized that first and foremost, studying the urobiome of, or the microbiome of the urinary tract is not the same as studying the gut or the oral cavity, where many of the protocols have been developed. And we really needed to come to a consensus and provide some kind of standard operating procedures for urinary tract microbial community studies. And so it's first important to think not only about the data itself, but where did this data actually come from? So thinking about DNA2 data, we have to keep in mind that nucleic acid isolation techniques do affect sequencing results. So they are not perfect. Some kits have biases, and these are well documented, and these could have a negative impact on any urobiome study. And so kits that were optimized and have been shown numerous times to work well for the gut may not actually work well for other niches or different environments that we're investigating. Furthermore, kits can have what we refer to as the kitome. So this would be the DNA that is transient through the kit. And so doing DNA extraction can introduce DNA from organisms that aren't really present within your sample. And so recognizing that there is DNA contamination that can come through the process of preparing your sample is important, because we don't want to be reporting upon a unique organism within our urinary tract when in fact it's just a result of the kit. Myself and others in the field have found that enzymatic lysis is generally more reproducible using, for instance, metanolysin, and lysozyme has worked quite well on urinary tract samples. Next, we need to consider purification methodologies. And so we can use silica column or magnetic bead protocols. And while silica columns can be really easy to use, they can shear DNA during extraction, whereas magnetic beads will give yields and purities that are similar to those silica columns, and they're easy to automate. So another paper I'd like to just draw your attention to, if you're not familiar with it, is by Lisa Karsten's group, and it was benchmarking different DNA isolation kits and how they performed on urinary microbiome samples. So now it's time to dig into some data, and there's 3 different types of data that I'm going to be talking about today. And the first is whole genome sequencing. And so this would be the case in which you're sequencing the genome of a particular isolate. For instance, an E. coli strain that came from a UTI positive patient. And so first and foremost, purification of this isolate is essential. Prior to sequencing, if we have not only the isolate of interest, but other contaminants, we have to recognize that we'll be sequencing them as well. And this could have some downstream effects during analysis. Also, at this point, it's important to think about the end goal of your whole genome sequencing project. So if the goal is to produce a draft assembly, then you can consider short read chemistries such as Illumina. However, if your end goal really is to have a complete genome, so one complete contiguous sequence representing that genome, then you might want to consider doing long read chemistries such as nanopore, or hybrid chemistries, meaning that you're going to do sequencing both with the nanopore as well as Illumina to get the benefits of both of those different technologies. In addition to whole genome sequencing, where we're looking at just a single member of the urobiome, we can also consider the community as a whole. And so there's 2 ways that we can do this. The first is amplicon sequencing. And so this is what, those fundamental studies of not only the urinary tract, but the whole human microbiome really focused on, with determining who is present. And so with amplicon sequencing, we typically target the 16S ribosomal RNA gene in bacteria and archaea, because the 16S ribosomal RNA gene has these variable regions, which we can determine the genus and sometimes the species that is present within a sample. With, for instance, fungal constituents of the urobiome, we often would consider sequencing the ITS region. And so it's important to think, if we're going to be doing a survey using these amplicon sequencing technologies, if we're going to be doing a survey of the urobiome, we need to identify which variable regions we should be targeting. And so not all variable regions are equal, and that not all variable regions can provide us with the granularity of taxonomic identification that we might be interested in. Furthermore, some of these variable regions are less informative about identification of urobiome-specific bacterial taxa. So another thing to consider is that amplicon sequencing is primarily done with short read technologies, although we've seen over the past couple of years People are exploring ways to use the long read technologies for this. But with the short read technologies, we're often doing paired end read sequencing, in which case we have 2 reads that we then overlap with each other to get that longer sequence. And selecting our primers such that we have a significant enough overlap is quite important, so that we don't have artifacts within that overlap, because as sequencing progresses, the quality of the sequencing decreases. The last type of data I want to talk about also captures that whole community within the ecological niche under investigation. And so for the urobiome, it's going to be able to sequence all of the microbial diversity found within that sample, and that's shotgun metagenomic sequencing. So in contrast to amplicon-based sequencing, we're not just sequencing a specific gene, but rather we're sequencing all of the genomic content present within that sample. And so you can think of this as taking a, for instance, urine sample from an individual and pelleting, extracting that pellet and getting all that DNA content that was present within that urine sample and sequencing it. And so one of the biggest challenges there is going straight from, a patient or participant sample to sequencing is the fact that human cells are very likely to be in that sample. And so we have to identify ways to deplete that human host DNA, because of course the human genome is far larger than these small microbes. And so we don't want to be spending all of our money sequencing the human genome over and over again, but rather to really target in on that urobiome. So to go a little bit more in depth on these different sequencing approaches, for whole genome sequencing, when we're sequencing, again, just that isolate, we can perform this on any sort of members of the urobiome, including bacteria and archaea, fungal pathogens or fungal commensals found within the urobiome, as well as the viral constituents. And so after performing our whole genome sequencing, we need to trim our reads because there are going to be low quality reads and bases. And so as part of our consensus document, we really vetted the different tools that were out there and how they performed for urobiome data. And so tools such as, for instance, Trimomatic and BB-Duck are really great to use when trying to remove those low quality reads and bases. With that high quality data, we can then go on to assemble our genomes. And as we've seen over the past couple of years now, the tool SPADES has really emerged as a robust tool that is constantly being maintained and updated and improved for doing de novo assemblies, such as we would do with a whole genome isolate. And then once we have our assembly, an essential thing to do is to really check our completeness. So did we actually capture all of the genetic content within that genome, as well as contamination that may have come from impure samples that might have been erroneously integrated into our assembly. And so tools such as CheckM are quite good at giving reliable predictions for both of those things. Now that we have that genome sequence, we want to get the information out of it. And so there's several different annotation tools publicly available. If we're just interested in identifying taxonomy of that whole genome sequence, we can use tools such as Metaflan. But if we want to get that gene annotation information, NCBI's PGAP tool, as well as PROCA, are commonly used tools for doing gene annotation. And as our database is filled with urobiome representatives, we've really seen an increased quality in the annotations being produced by these tools because we have more data. Annotations are often built upon experimental results and data that exists within the database. And so we're seeing an improvement in the quality of the annotations just over the past 10 years. And of course, if an individual has a specific use for this data, or a particular condition that they're interested in investigating further, or potential symptoms, that are emerging as a result of this microbe. There's numerous different tools to really narrow in on particular aspects of a genome that might be more interesting. So moving on to these community-based, because the urobiome really is moving in the direction of not only looking at the individual isolates coming from a sample, but really this whole community that exists within the urinary tract of healthy as well as symptomatic individuals. And so with Amplicon sequencing, as I mentioned, we typically are targeting either bacterial or archaeal, and there have been lesser number of studies that have really started looking at the fungal communities there within. But regardless of the 16S or ITS target, important steps of Amplicon sequencing bioinformatic analysis include removing chimeras, which might arise because of PCR and those errors with regards to the overlaps as we put together the two reads that are produced for a single variable region or ITS. And there are several tools out there for that. But then we can really start asking those questions that are the heart of Amplicon sequencing, which is who is there? And so there's two different strategies that have been used for grouping reads that are representative of the same species. The first being OTUs, or operational taxonomic units. And what has kind of emerged in the past 3 to 5 years as being the preferred method is ASVs, or Amplicon sequence variants. And so in this step, these tools such as Mother, Data2, Time2, and Doppler, they're identifying identical represents of the same organism. And so it's grouping those reads that are from the same species. Now that we have those groups, we can really determine who is there. And this requires looking at existing databases. And so in essence, matching those Amplicon sequences to these databases to assign taxonomy. And so there are a couple databases out there. And again, Lisa Carson's group did a study in which they looked at the quality of these databases with assigning taxonomy for urinary tract bacteria. And so based upon that study, they found that the Silva and the NCBI 16S databases are in fact the best. They've got representatives from the urobiome in their collection. And another thing to consider, as I mentioned previously, we can have things such as the kitome, which is those DNAs that are coming in as part of the preparation of the DNA for sequencing. But we also have to recognize that most urinary tract samples are in fact low biomass. So this is in stark contrast to the gut, where there's a huge microbial community. And so as a result, contaminants seem to be more likely in the sequencing of these samples. And there are bioinformatic tools to assist with detecting and removing those contaminants, such as decontam. But also, this is another time to return back to the whole preparation of this data with regards to your experimental design. So including negative controls that really are sequencing that kitome. And another option is to include mock communities where you can actually measure any sort of contaminants that might have been introduced through the process of the sequencing experiment. And last but not least, with regards to shotgun metagenomic sequencing, with shotgun metagenomic sequencing, we have the benefit where we're not just targeting a specific gene again, but we're getting all that DNA. And so as a result, we can actually be sequencing the viral community, which is actually where I study. And with that, the viral community, which could either be bacteriophages or viruses that infect bacteria or human viruses, there is no one conserved region. So we don't have the option to do Amplicon-based studies on viral communities. But when we take that whole entire community and sequence it, we often find that we have human host DNA sequences there. And so to remove them, we can use tools such as Bowtie2, which will map all our reads to the human reference genome, and we can remove them from the rest of our analysis. Again, with shotgun metagenomic sequencing, we need to trim our reads and assemble them. And there's tools such as Metaspades, which is just built off of that Spades algorithm I talked about earlier, that can do de novo assembly. And there's also several different tools for binning sequences. So these binning tools are identifying reads that are likely to belong to the same individual organism. And this can help facilitate quality metagenomic assemblies. Now that we have that whole genetic content, we obviously want to do some analyses. And so we can do taxonomic as well as functional analysis. So we can go beyond that Amplicon sequencing study that was identifying who was there, but we can actually ask, what are they doing and how are they potentially interacting with each other? And so there's several different tools out. Onvio and MD-RAST I just mentioned, because they can not only do the annotation for you using many of those previously mentioned annotation tools, but they can also easily facilitate comparisons between samples. And so Onvio is a program that you run locally on your machine, and MD-RAST is a web-based tool. So as we are at the forefront of urobiome studies, bringing together enough studies such that we can actually look at a large patient population or a participant cohort requires us to be able to integrate perhaps other sequencing results from other studies. It also helps us be able to compare the results of our studies to another. And so the ability to reuse existing data sets or to be able to reanalyze existing data sets as tools improve necessitates the availability of raw sequence data. And so tools such as, databases such as NCBI's SRA or EBI's ENA are great resources to find raw sequence data from urobiome studies. In addition to that nucleic acid data, we also need metadata. And this is going from the process of sample collection to the actual generation of that DNA sequence and everything in between. So if you're interested in comparing your study, which for instance looks at the urobiome of individuals with LUTs, and you want to compare it to individuals without LUTs, there may be data sets that are out there publicly available that you could use to increase your cohort and provide greater insight into the diversity. And so with good metadata, we can reliably pull in those other data sources. And so as a result of our urobiome study, we put together the MixS urobiome collection. And so if you're not familiar with depositing data with NCBI, there's different standards that they request that you follow, and there's required data elements for each individual study that you're providing to the public repositories. And so as part of our consensus, we put together that list of what do we think should be required for the depositing of raw data related to urobiomes. And so what I've listed on this page is just a snapshot of the metadata collection that we're recommending as part of that consensus study. And so you can see many of the different aspects that I talked about throughout my talk here today, but other things with regards to the patient or the participant's age and sex, as well as many different factors, which we've not included here in the required data set, but as recommended data sets with regards to, for instance, their LUT status. So in conclusion, I want to thank, and hopefully I've done a good job at representing this work as part of the Urobiome Consensus Group. And again, if you've not read this paper, I highly recommend it. And if you're interested in learning more or talking more about ways to analyze urobiome data or standards for urobiome research, I highly recommend that you come and visit for the 2022 meeting in March at UC San Diego. And I couldn't find a better view that shows that this meeting is essentially on a beach. So thank you very much.